much. I'd like to thank Sergey and the rest of the directing committee for the invitation. I consider it a great honor to speak here in Brazil. I want to share with you some more techniques than evidence today, and I know everybody here has varying levels of experience on trauma, but really I'd like to send you home today with some ideas, tips and tricks for managing things when subtrochanteric fractures fail. So this is a very typical image that I think all of us have seen, a very typical approach to a subtrochanteric fracture, and you see the common deformity here and the problems with the bone and the implant that you're going to face. When I think of this problem, I think there are probably three main challenges that I think you need to attend to. I think you need to first make a decision about whether or not this can be salvaged or not. That may be your most significant decision, okay? And that can be based on some evidence, but may be experience and skill. Most of the time, I'm a traumatologist, I'm gonna try to do a salvage. And then for me, removal of the broken implant becomes a major issue. And I'm hopefully gonna give you some tactics for dealing with that. And then finally, I think getting a reduction in these situations is very challenging. These patients have been stuck in a varus position. The bone quality is extremely poor. And so there's lots of challenges in both realigning and then getting solid fixation. So I will talk about these three topics with you. There is very little good evidence, and so I won't spend a lot of time on evidence. Interestingly, there has been some reviews that have looked at different techniques for revising when a nail for a subtrochanteric fracture has failed. Interestingly, when you try to look at functional outcomes between all the different possible revision options, from a new nail to a plate to an arthroplasty to a tumor prosthesis, it's very difficult to detect differences in outcome, and I think that tells you that there probably is no single best way to do it. Interestingly, in North America, one commonly described option is a tumor prosthesis, an endoprosthesis, and I don't know if this is a common option here or not, but I think even when you look at the very best literature from this, the complication rates are quite high for an endoprosthesis for a failed subtroch fracture, with a high reoperation rate, a high rate of dislocation, and then probably most problematic, a high rate of infection. When they looked at their series of patients in this paper, they did find that after the year 2000, maybe with better implants, some of the complications decreased, especially the dislocation complication as well as the loosening, suggesting that maybe better technology is available these days than used to be available, and that maybe in the future an arthroplasty is a more reasonable option than it is now. Okay, so now I'm going to get to the main part of this talk, which is the salvage techniques that I'd like to share with you on this topic. Really, these are tips and tricks for your practice. So I'd like to share with you something that may not be so exciting, but I think will be critical. It's hardware removal techniques. So especially when you have a broken intermedullary nail. And the biggest challenges here are removing the nail from a deformed proximal femur. So my first technique is to actually remove the nail from the original nail path in which the nail was placed. Okay, this is best when the deformity is minimal or minor. So here's that common varus failure, and the failure of the nail, and the O is in the common place, either where the screw goes through the nail or where the nail flares to a smaller diameter. Okay, so in this situation, you could remove the compression screw, and if with enough leg manipulation, you can access it sometimes through the fracture and push the implant up through the non-union site, and then grab the implant from the top with some modification with a joystick perhaps to realign the proximal fragment. The distal fragment, again, has no connection, so we use the common technique of passing multiple wires through the nail and then trapping them back in the end of the nail. I think you're probably familiar with this technique. The idea of a small ball tip being passed through, sequential smaller wires, and then entrapping and pulling the nail out. So that technique is removing from the original path. Here's another example. Again, removal of the compression screw. Here, removing the proximal remnant through the insertion site. One thing not to forget, sometimes there's so much varus that the implant can get incarcerated or blocked on the passage out. But don't forget, even though you're not at the stage of doing the reduction, you can still introduce a reduction clamp to improve the alignment, to help remove the nail remnant from the distal segment. The second technique is removal through the non-union site in the subtrochanteric region. This is something I use when the deformity is much more severe. So in this situation, you have much more varus. This is an example of extreme varus of the proximal segment. This is a very challenging hardware removal point. So again, removal of the compression screw, but here we access first the distal fragment of the nail through the non-union site itself. And this, you're able to remove it again using the multiple wire technique that I showed you before. And here, pulling it out and then removing the proximal remnant through the non-union site as well. Okay. So those techniques, I think, are pretty helpful for removing the implant. And then now you move on to deciding how to do the salvage procedure, okay? I love plates. But a lot of times in this patient population, especially the elderly population, plate salvage can be challenging. For me, when I think about using plates, it's usually in younger patients. It's usually when there is reasonable bone stock remaining, as well as a good amount of bone stock remaining. And it's also, plates for me are best when the patient can protect some weight from the reconstructed construct. So many elderly patients, plates are not appropriate for a lot of these reasons. First thing I think about when I think about revising to a plate, or one of the reasons, it has to do with nail containment. I think the stability of a proximal femur nail is very much related to the amount of bone you can get around the proximal part of the nail. Here's an example of a failed proximal femur nailing. Okay, not good. But the question I have, if I want to try to revise this with another nail, is will there be containment of bone around the new nail site that gives it stability? So in other words, has there been damage to this critical lateral bone that adds to the stability of a proximal nail that would give me stability for the nail? In this case, I really didn't think that, I thought it had been damaged by the nail attempt, and this was a younger patient, so we used a standard angle blade plate to do her reconstruction. In very good bone, she's a younger patient, she goes on to uneventful union. Sometimes if I really I want to use a plate, especially if I want to get a reduction aid as the plate, I'll think about doing impaction grafting. I'll borrow a technique from the arthroplasty surgeons, okay? So here's a case of a patient who has a varus failure of a subtrochanteric fracture. This is a very common variant. But note, just looking at the film, the differences in the proximal bone density around the implant from the non-union and from the non-weight bearing, the disuse. So in this situation, we note that this patient has progressive deformity and pain. This is a non-union. So I will again start by removing the broken implant, but you can see here I've impacted allograft into the nail path very aggressively to sort of restore the proximal bone stock. Once I've done that, it feels like a much more solid proximal fragment, and I can use, again, my standard implant in a young patient, and that's going to be an angled blade plate. Again, for getting great proximal control, reduction in the frontal plane, and then for me, what's critical is the use of mechanical compression to optimize stability in these fractures. And again, these patients under this highly compressed, well-reduced alignment will go on to uneventful union very typically. And here the patient's full weight bearing at 3 months, pain-free. Another very useful compression technique for plates in this setting is this idea of offset or mismatch loading. And that idea is that if I can configure the bone fragments in a very specific way and compress them against each other than against the plate, I can even get more compression than I can from a mechanical device. So here's a very stiff non-union. This is a non-union, it's painful, but it's not mobile, but it's a simple pattern. And this is a pattern where I really want to optimize compression. So in this pattern, again, I've removed the implant, I've done some impaction grafting, but here I have the blade plate going in, but I set the blade plate, but I set the distal fragment off the bone, off the plate initially, and then I contact the bone ends. Now you can see there that if I add screws to the plate shaft, the bone has nowhere to escape but to compress into the non-union site by the configuration of where I've set the bones before I place the screws. So here we put them in the offset position or the mismatch position. As I pull the distal fragment back to bone, I create tremendous amounts of compression. I create so much compression that very frequently you can break the screw heads off. It's causing so much force. And as you pull it in, you get very, very aggressive compression and very, very good healing. Again, sometimes you have to be very careful if you're going to use plates about the medial contact. Here's a severe varus deformity. The removal of the implant. For me, again, the use of the mismatch loading and the varus and the valgization position. But as you can see in my post-op images, the realignment looks good, but the medial contact is limited. And I will warn you that you must maintain medial contact, and here you see what happens if that fails. The treatment for this is standard for me and very reliable, and that's a valgization osteotomy with an offset angle blade plate. And this goes on to uneventful union. Nail salvages for me are more in older patients. I would never use a plate in a very elderly osteoporotic patient when the bone quality is poor. And I especially use them when I anticipate that the patient's going to weight bear immediately. Okay, and so here's a patient of mine, 52 years old, mild brain injury, multiple fractures. I will admit this is my patient. This is my early idea of a plate reconstruction with some simplification of the fracture and then a plate. And then I go to add compression, and note the medial reduction is okay or average, but I add compression mechanically. And in doing so, I change the medial reduction. I worsen the medial reduction. So can you suspect what will happen here? Yeah, that's going to fail, okay? And so for me, not having medial contact or medial reduction is really important. So two good examples. Here I choose to go with a nail. And again, really still focusing on getting a medial reduction and really getting an improved result. One technique I find is very useful is called intracortical screws. This idea is to use lag screws, small fragment lag screws, to reduce and hold the fracture prior to nailing. Okay, so this is placing screws outside the nail path to allow for nailing. Okay, so here's what this looks like. This is a patient came to me, looked good on the AP, nothing hurts a reduction, like looking at the lateral. That's not a good reduction, okay? But this is a simple fracture pattern. So I remove the implant, I reduce it with a clamp via small open lateral approach, and I add 2 small fragment screws outside of the nail path to hold the reduction. Once those screws are in place, then it's easy to nail essentially an intact femur. So these nails are strategically placed outside of the path of the nail, and the reduction is simple. The nailing is much simplified. Hybrid fixation is something we use distally. It's also feasible proximally in the femur. Think about that. Here's a severe varus failure. These are very typical in appearance. Here we've mobilized the non-union. In order to achieve the reduction, it's taking a lot of clamp force, and I'm actually creating fracture as I'm trying to do this. It's simpler here for me to use a plate to reduce the fracture, reduce the frontal plane deformity, and add compression. Once I achieve the reduction, I change the screws to unicortical screws. Here then I can add a nail to improve the stability for weight bearing, and in this case, it's a very narrow path, and so I don't use a femoral nail, but instead I ream in place a piriformis path, but I use a tibial intramedullary nail. And so here's a tibial nail going down in the reduced path and holding the reduction, and then allowing this elderly patient to weight bear immediately. A couple quick augmentation cases. This is something I use, augmentation with buttress. Here's a varus failure of the reverse oblique pattern. The patient's having severe pain. This is early follow-up. We remove the implant. The reduction is simple, but I will warn you, using clamps in older patients is very dangerous because you can definitely create fracture. And I felt with this clamp I was creating fracture, so I have to use a different tactic. Here I'm getting my nail start site, but I switch to a temporary lateral hook so that I can use a more gentle clamp reduction. Then I pass the nail, a very medial start site. Creaming, nail placement. Here we were concerned with the placement of our compression screw that the old nail path was nearby, and the anterior bone quality didn't look optimal. So in this case, we've deployed the nail, but in a sort of atypical situation, we added augmentation of cement through the nail to add stability. And then for me, for all reverse obliques, I always add lateral buttress to limit the shortening of the nail. That plate is a DCP plate, and it does not block the compression screw. And the healing is uneventful typically. And one last case. This is a very old patient, 95 years old. She fell working in her garden. She was unable to walk. Some people at 95 would suggest an arthroplasty. We felt that she merited a reconstruction due to her activity level and the simplicity of the fracture. So we removed the nail, the hook plate for frontal plane reduction. Here I show you the technique of blocking screws to medialize the nail path to add stability. So here I ream in a piriformis start site, but I put a blocking screw to push the nail medially to improve the reduction, improve contact of the nail proximally. Here we added augmentation because the bone quality of the head looked poor, and the buttress. 6 months she was doing great. So in conclusion, again, there's a variability in failures, but there are common patterns to recognize. Multiple techniques are utilized. Both plating and nailing are feasible for sure. You have to have lots of tips and tricks for these, but I think overall you have to be very creative and aggressive. Thank you very much.